Okay, so it is my pleasure to open the scientific meeting with the results of the baccalaureate trial. Joining us from Nantes in France, we have Karine Assenoun and his colleague Mick Vuj. We have from London, Kathy Rowan, from Aberdeen, Marion Campbell, from Copenhagen, Morten Highlander Muller, and from Melbourne, Chris Nixon. Waleed Al-Hazani from Hamilton, Canada, will be delivering the editorial. The baccalaureate trial investigates baclofen for the prevention of the alcohol-addicted patient for the prevention of agitation in the alcohol-addicted patient in the intensive care unit. So without further ado, over to Kareem and Michael.
Thank you. Thank you very much, Rob. We're very happy to share the results of the baccalaureate trial in this meeting. We are very happy too because the paper was just accepted yesterday in the JAMA, so it's really an honor for us to share the results of the baccalaureate trial and to discuss, of course, with the panel and with the audience about these results. So first of all, some background. There are mainly three messages regarding the consequences of alcohol use in high social demographic index location. First, 2.8 million deaths were attributed to alcohol use. Second, alcohol is the seventh leading risk factor for premature death. And third, there is really a high prevalence of unhealthy alcohol use in high social demographic index location. So what is the definition for unhealthy alcohol use? There is a clear definition, which is more than 14 drinks per week for healthy men up to 65 years old, or more than 7 drinks per week for women or older men. It includes patients with or without alcohol use or dependence. In this study from the ICU team of Rennes, they did participate to the baccalaureate trial. They evaluated the consequences of at-risk drinking, and they found an increased risk of ICU-acquired infection, an increased risk of death in the ICU up to 1 year after discharge, regardless alcohol abuse or dependence. So the first message could be that there are consequences on outcome for patients in ICU when they are unhealthy alcohol use. We and others have evaluated the influence of alcohol abuse on agitation, delirium, and sedative requirement of patients admitted to an intensive care unit. And if we compare the incidence of agitation between the two papers, we see important difference. First, as you can see, can you see the pointer? Yes, okay. So if you look at the agitation between the two papers, you can see that for a low risk alcohol user, there is 31% versus 50%. And if we are looking at unhealthy alcohol user, this is 42% versus 66.8%. So the problem here is related with the definition of agitation. What is exactly agitation? Is it patient that bite the tracheal tube, or a patient with tachypnea, or patient ventilator asynchrony? It's very difficult to answer if we're looking at the current literature. So another way of thinking is to evaluate the consequences of alcohol use disorders. And in our study, we found that the time on ventilator was higher, and the rate of ICU-acquired infections was higher in these patients. So considering these evidences, it is obvious that agitation has major consequences on the outcome of ICU patients. First, short-term consequences like hinder medical care, pulling out line, catheter or drain, unplanned extubation, removal of restraint, etc. Midterm consequences are increased time on ventilator, ICU-acquired infection, long-term psychological and cognitive sequelae. So there are clearly consequences of agitation in this kind of patients. So we can consider some patient-centered outcome to figure out if unearthly alcohol use has really consequences for these patients. So now the question becomes, as agitation is frequent in patients with unhealthy alcohol use with deleterious consequence, how can we prevent this complication and take care of this patient? Unfortunately, there is absolutely no answer to this question because there is no recommendation for the prevention of agitation delirium in patients with unhealthy alcohol use in the ICU. But we know that among the molecules currently available, Baclofen is a good candidate. And in France, since 2014, we have a temporary recommendation of use in outpatients up to 300 milligrams per day. This is a recommendation from the French Drug Agency. So the problem is that the level of evidence for using Baclofen is weak. But interestingly, if we are looking at these studies, the red studies are for low dose and the green studies are for high dose. As you can see on this slide, the two positive studies used a high dose, what we call a high dose, of Baclofen, which is above 150 milligrams daily. But again, we don't have any proof of evidence for using such a dose in ICU patients. So if we want to use Baclofen in ICU, the first step is to evaluate pharmacokinetics and toxicity of the molecule, presumably high dose, if we consider studies from the latter slide. This is exactly what we did. We studied 20 patients with unhealthy alcohol use under the NIAAA criteria, under mechanical ventilation for an expected duration above 96 hours. And we obtained in this pharmacokinetic study two main results. Firstly, I show you the validated pharmacokinetics model we used to adapt the dose of Baclofen to the renal function could be applied to our ICU patient. Secondly, and this is really interesting, you can see that the incidence of agitation in unhealthy alcohol users was receiving Baclofen was 25%, a lower incidence as compared to our first study without Baclofen use, where the incidence was 42%. This huge decrease suggests the potential effect of the molecule for the prevention of agitation and agitation-related events in the population of unhealthy alcohol users hospitalized in ICU. So overall, this is the background for performing the Bacloria trial that Michael will now present to you.
Thank you, Karim. So we decided to design this trial named Effect of High-Dose Baclofen on Agitation-Related Events among patients with unhealthy alcohol use receiving mechanical ventilation, a randomized clinical trial. So this study was a randomized multi-center double-blind placebo-controlled study including 18 participating centers from university and district hospitals. The main objective of the study was to assess whether high-dose Baclofen could reduce agitation in patients with unhealthy alcohol use under mechanical ventilation compared with placebo. This study included patients from 18 to 80 years old with expected duration of mechanical ventilation above 24 hours and a weekly alcohol intake, which was classified as unhealthy according to the National Institute on Alcohol Abuse and Alcoholism, namely more than 14 drinks per week for men, or more than 7 drinks per week for women or men older than 65. Patients were included after next of kind consent or emergency inclusion or self-consent obtained before intubation. Patients with hospital stay of more than 7 days before randomization could not be included. So as patients with mental impairment, brain or spinal cord injury, or already exposed to baclofen or with contraindication to enteral route medications. Patients with, so after inclusion, patients with randomized were randomized through an online remote system, and the randomization sequence was stratified on the participating center. Manufacturing of the treatments was centralized by the pharmacy of Nantes University Hospital, so as baclofen and placebo could not be differentiated. In the end, clinicians, nurses, investigators, the statistician, and the Data and Safety Monitoring Board were blinded to the randomization group. So after randomization, patients received a loading dose of placebo or baclofen from 50 to 150 milligrams through the feeding tube according to their glomerular filtration rate estimated by MDRD equation. Then patients received from 50 to 150 milligrams per day of treatment according to their renal function, divided into 3 intakes from day 2 to day 15. At the end of this period, the treatment was gradually reduced over 3 to 6 days, depending on the renal function. This period was shortened if extubation or tracheotomy occurred before day 15, and in all cases, the treatment was stopped on ICU discharge. The treatment was temporarily discontinued if the renal clearance was below 15 milliliters per minute without renal replacement therapy, or if the liver enzyme were above 20 times the normal rate, or if heart rate was below 50 beats per minute. The treatment could also be definitively discontinued if allergic symptoms or seizure or mydriasis occurred, or if heart rate was below 35 beats per minute, or if the patient presented delayed awakening, namely eye not open 72 hours after sedation interruption. So the previous slide, to assess retrospectively the residual plasmatic concentration of baclofen, blood samples were drawn in 80% on day 3, on 80 participants on day 3 and day 10 after randomization. So the primary endpoint of the study was the occurrence rate of at least one agitation-related event over the treatment period. Agitation-related events were defined as unplanned extubation, pulling out lines, catheter, and drains, falling out of bed, elopement from the ICU, immobilization device removal, or self-aggression or aggression toward medical staff. The secondary endpoints were the occurrence rate of at least one agitation-related event by day 28, the total number of agitation-related events in each group, time on ventilator, the quotation of the Ricker sedation agitation scale, the total dose of sedative and analgesic, the rate of ICU acquired infection, the length of stay in the ICU, and death. For the sample size calculation, in our 2 preliminary studies, the rate of agitation was 42% in unhealthy alcohol user compared to 31% in low-risk user, and compared to 25% in unhealthy alcohol user receiving baclofen. As a result, we assume an average reduction of 15% of agitation in baclofen group compared with the placebo group, with a 5% type 1 error and a power of 80%, meaning a sample size of 314 patients. So this slide is difficult, yes.
But it works.
So here are the results of the study. So over the study period, 2,146 patients under mechanical ventilation from 18 to 80 years old were identified as unhealthy alcohol users. After the exclusion of 1,832 patients, finally 314 patients were randomized. 159 in the Baclofen group and 155 in the placebo group. In the Baclofen group, one patient withdrew consent, one did not receive the treatment because the antiviral route was not available. In the placebo group, one patient was included twice in the study for 2 different ICU stays. All randomized patients were included in the final analysis. So at baseline, patients were mainly middle-aged men with simplified acute physiology score between 46 and 49 points, meaning a probability of death in the ICU between 34 and 46%. The median alcohol intake was 5 units per day. About 15% of the patients had positive alcohol blood test on admission, and the 2 main diagnoses in the ICU were acute respiratory distress syndrome and septic shock. Regarding the primary endpoints, so 19.7% of in the Baclofen group versus 29.7% in the placebo group presented at least one agitation-related event over the treatment period. This difference was significant. This analysis included all the randomized patients. The 2 missing data for the primary outcome, namely 1 consent withdrawal and 1 patient with antiviral route unavailable, were handled by multiple imputation. The sensitivity analysis, considering death as a competing event of agitation, confirmed this significant result. I will show you the cumulative incidence plot in the next slide. And these results were consistent in the per protocol analysis. Here are the graphical representation of the cumulative incidence plot for the primary outcome, considering death as a competing event. So you have the primary analysis on the left-hand side and the per protocol analysis on the right-hand side. The horizontal axis corresponds to the time in days. Regarding the secondary outcomes, so the incidence of agitation by day 28 was not different between groups. However, when you compare the number of agitation-related events in each group, there were more events over the treatment period and at day 28 in the placebo group than in the Baclofen group, so a difference which was also significant. The median duration of mechanical ventilation and stay in the ICU was significantly longer in the Baclofen group than in the placebo group. There was no difference in the mortality rate at any time points. Here are presented the details of agitation-related events in each group over the treatment period. So 45 for Baclofen versus 79 for placebo. And at day 28, 70 for Baclofen versus 111 for placebo. Here are presented the monitoring for sedation. So there was no difference for the cumulative or the daily doses of hypnotics and analgesics between groups by day 28. You will notice that patients in the Baclofen group spent more time with recurrent sedation agitation scale from 1 point, namely patient unarousable, to 3 points, namely patient difficult to arouse. Regarding the adhesion to the protocol, patients received in mean more than 90% of the protocolized dose of Baclofen or placebo. Treatment was mostly temporarily discontinued in both groups for acute renal failure with clearance below 15 milliliters per minute without prescription of renal replacement therapy. The treatment was definitely interrupted for delayed awakening in 14 patients in the Baclofen group compared with 3 patients in the placebo group. The monitoring of the residual plasmatic concentration at day 3 and day 10 after randomization revealed that the concentration were below the toxic threshold of 1,100 nanograms per milliliter among all patients who were tested. So it is the first randomized controlled trial to study the role of baclofen in order to reduce agitation in the ICU. Moreover, baclofen was used in addition to standard of care, which increases the feasibility of implementing this molecule in our clinical practice. The mean adherence to the protocol was high, and no specific events apart from deep sedation was detected. Finally, the reduction of agitation appears as a major patient-centered outcome because it has the potential to reduce the incidence of post-traumatic stress disorder after ICU stay. This is a post-hoc analysis which is ongoing. This study had also several limitations. First, the 10% difference between groups was less than the study was powered to detect. This difference appeared to be clinically relevant since each agitation period involved possible risks of injury for the patients, but also for the medical staff and can hinder medical care. Dosing of the treatment was not adjusted to sedation scale, which could explain deeper sedation in the baclofen group. The study used higher dose of baclofen than the current recommendation. However, it corresponded to the temporary authorization of use when the study was designed, and all the baclofen plasmatic concentration were below the toxic threshold. Baclofen is a GABA agonist, which may increase delirium in the ICU. However, the causality link is uncertain. There was no standardization of the prevention and the treatment of alcohol withdrawal syndromes. Nevertheless, no recommendation is available so far. Finally, there was no distinction between hyperactive form of delirium and agitation without delirium, which would have required to assess delirium and agitation scale together. So in conclusion, in unhealthy alcohol users under mechanical ventilation, high-dose baclofen, in addition to standard of care, reduced agitation-related events compared with placebo. Nevertheless, this could also increase the depth of sedation, the length of stay in the ICU. Dosing should be optimally adjusted according to the sedation scale and the estimation glomerular filtration rate. Thank you for your attention.
Fantastic, Karim and Michael. Brilliant presentation. Thanks very much. Very, very interesting data. We'll move on now to the editorial, which will be delivered by Walid Al-Hazani from Canada, Hamilton, Canada. Walid is an intensivist, a gastroenterologist, and a noted methodologist, and he has led the sedation, agitation, and pain guideline for SCCM and the surviving sepsis guideline as well. So he is excellently placed to comment on this trial. Walid has provided a pre-recorded editorial, so we'll play that now.
Hello, everyone. It's a great pleasure to be here today and share with you my thoughts about an important and interesting clinical trial, the Baclofen trial. I have no conflict of interest that are relevant to this topic. First, I would like to congratulate the authors of this trial and other trials presented during this meeting. And it's just a reminder to all of us in the scientific community and also to clinicians that we always stand on the shoulders of giants. And by giants, I mean scientists and researchers, so we can see further and advance ahead. And any thoughts that I'm sharing in this presentation is purely from an academic interest, but I truly appreciate the effort that the authors have put into this trial. Okay, the research question, if I were to phrase it, I would phrase it as the following. In mechanically ventilated adults with alcohol use disorder, does the use of high dose baclofen compared to placebo reduce the risk of agitation-related events? So is this question a priority? The burden of alcohol use disorder in the ICU is unfortunately not clear. Not too many studies have been done on this topic. So we really don't know, although anecdotally, and these patients probably are sicker, and some studies have suggested that alcohol use disorder is associated with increased risks of agitation and delirium. I think we can all attest to that as clinicians from anecdotal and dealing with these patients. So it's clearly an understudied a problem. And I would say, yes, this question is of priority, and we really need more studies to address areas of clinical practice that are understudied. Is there biologic plausibility? Probably. We know that the consumption of alcohol can be suppressed either by a GABA A receptor antagonists or GABA B receptor agonist like Baclofen. Unfortunately, I could not find any RCTs on this topic in the ICU. So it became of a clear interest to see if this medication would work in this context. But if you look at other population, for instance, patients with alcohol use disorder as an outpatient, and there are some small RCTs that showed that Baclofen may improve alcohol abstinence in this population. Guidelines on helping clinicians to manage those patients, like the ASLD guideline, list Baclofen as one of the options for this population. So there is some biologic plausibility, but this is in the context of outpatient and a longer term use and with completely different outcomes. One issue that I like to bring up most of the time, I do believe that pilot trials are a crucial component of any research program. There are many lessons that we can learn from conducting pilot studies. Although I couldn't find pilot phase of this particular trial, authors could have benefited from conducting a smaller pilot or a vanguard study to address some of the issues before proceeding with the larger clinical trial. We'll talk a little bit about several methodological points. We'll start with randomization. We look at the randomization. I think authors did a good job selecting central randomization ratio of 1:1 with fixed blocks. That has been used. That have been authors been blinded to the blocks, but they also stratified by center. So about 18 centers were included. Another way to assess randomization is to look at table 1. This is when you look closely at table 1, you would see that there are some imbalances, small, not very large, but there are some imbalances that you probably shouldn't be seeing with randomizing of 300 patients. For instance, if you look closely, even a gender balance was a little bit off. Patients in the Baclofen arm had higher SAPS-2 score, severity illness scores, and slightly higher SOFA scores. More advanced cirrhosis as well was found in the Baclofen group, and even worse alcohol dependence was found in the Baclofen group. While this could be play of chance just because of small sample size, I would expect the groups to be more balanced. Another possible, again, maybe less likely explanation or contributing factor is overstratification. With smaller sample size studies, it's important to stratify by center. However, if you have a large number of centers and realizing that in this population it's probably difficult to include or finish the trial in one center, as these patients don't constitute a big proportion of ICU patients. So it makes sense to involve many centers. But again, as you can see, there is a huge variation in terms of recruitment across these centers. Well, could have this contributed to the observed imbalances, or could it be a play of chance? It's very difficult to say, but it's worth highlighting that there is at least numerically some imbalances between the two groups. So that's the first point I'd like to make. When you go to blinding, I think authors did a great job. They used placebo to blind patients, obviously, who were sedated, intubated, investigators, healthcare team, I assume data collectors as well, although in the article they refer to double blinding, which could mean different things to different people. I'd like to break down blinding by groups. I couldn't see any mention of adjudicators, so it's hard to comment if there were adjudicators involved and whether they were blinding. And when I mean adjudicators, I mean adjudicators of the outcomes of the trial. And also wasn't clear to me if data analysts were blinded during the analysis. But overall, I have no major concerns about blinding, and I think the authors did a great job. After the patients were randomized, we always worry about co-interventions and their effect on the trial outcomes. Authors did a great job promoting a protocolized sedation approach for nurses and advocated to targeting a RASS score between -2 to +1, which is where somewhere in the appropriate light sedation, unless the patient obviously needed deep sedation if they were too sick and with ARDS, for example. When you look closely at the medications used in both arms, the sedative agents, again, reasonably balanced, maybe numerically more patients in the Baclofen group receiving midazolam, again, could be related to the severity of alcohol abuse that we've seen in table 1, or could be just, again, just a fluke from just a random observation. I couldn't find the average RAS scores post-randomization throughout the conduct of the trial. Maybe it's mentioned somewhere, but I wasn't able to find it. Authors did provide the RAS score at baseline. However, we could look at the Riker sedation agitation scale as a different surrogate. And they did report the number of days in which patient achieved different scores. Remember that the lower the score, the more deep the sedation is. So score 1 to 3 is anywhere between unarousable to sedated. So kind of a deep sedation, although this is meant mostly for agitation detection. But if you look there, patients in a Baclofen arm spent more days in this target range of deep sedation compared to the placebo arm. We're talking about an average of 2.5 days, so 2.5 days longer in the deep sedation arm. While this could be a result of receiving a high dose Baclofen, which has some sedative effect. It's hard to say, but it's worth mentioning that these patients were more sedated, obviously. You come to the outcome phase. The agitation-related events was the primary outcome. And authors looked at this outcome. Their primary outcome was throughout the administration of the study drug. It's kind of a composite outcome, and they did break it down in the supplement very nicely. And as you can see, the Baclofen group had less number of events compared to the placebo group, and mostly driven by unplanned extubations and medical device removal. You want to put this into perspective in numbers. I like to present things visually. It makes it easier to understand. So this is an absolute scale, and the line in the middle represents no difference between the two groups. And as you can see, the point estimate is suggestive of at least 10% absolute reduction in agitation-related events. However, the confidence interval was extremely wide, ranging anywhere between an implausible reduction of 20% to a trivial reduction of less than 0.5%. Usually, as the clinicians, we set a minimally important difference. In an ideal situation, I would have asked the audience what they think, but we don't have this luxury while presenting online. So I'm going to propose a couple of scenarios. The first scenario where Baclofen is considered by clinicians to be toxic or associated with adverse events, and then the minimally important difference need to be larger in order to convince people to use this medication. But even in a scenario where, medication is considered to be safe, cheap, available, no downsides, and people say, okay, we'll accept, a 1% absolute reduction in agitation-related events to use this drug. Even with this very small, minimally important difference, the confidence interval still cross that minimally important difference. So there is an element of imprecision here. Not only that, with time as the secondary outcome, they looked at the same events at 28 days. As you can see, now the upper limit of the confidence interval crosses the line of unity, suggesting cannot exclude even harm. So there is some element of imprecision, which is one of the issues. Second question that comes to mind, is this high dose safe? Just to give some perspective, the typical doses of baclofen in alcohol use disorders, at least to my knowledge, is anywhere between 15 to 60 milligrams per day. The trial used 150 milligrams a day, which is 10 times higher than the lowest dose and at least 2.5 times higher than the maximum dose. So it's a quite high dose of baclofen. Definitely, I personally have never used it with this high dosing in the ICU. The authors, to the credit of the authors, did a great job of conducting a pharmacologic study on 20 patients with alcohol use disorder in the ICU, and they looked at the pharmacokinetics and toxicity, and they found that with this high dosing, the serum levels were within normal range and no major toxicity, and they also looked at the pharmacokinetics, suggesting some renal adjustment doses in critically ill patients, which they based their intervention on in the trial. Well, what did they find in the study? As you heard from the authors, adverse events were higher in the baclofen group, and if you look at it closely, just calculating the odds ratio, we're talking about 3.5 fold increase in risk of adverse events requiring drug discontinuation, mostly delayed awakening, again, consistent with the deep sedation that we've seen the authors describe in the table that I showed you before. Other outcomes as well were affected. So patients who received baclofen had longer duration of mechanical ventilation and ICU length of stay, a mean difference of 2 days longer compared to placebo group. Again, the confidence interval could not rule no difference, but the point estimate was not in favor of baclofen. Looking at mortality, again, the confidence interval is extremely wide, but the point estimate was going the wrong direction, suggesting increased risk of death, but again, it's uncertain. Again, is this related to the fact that the groups were imbalanced is hard to say. When you put everything on a scale to weigh the pros and cons of this intervention, so far, if we believe the results about agitation events, we're talking about an absolute risk reduction about 10%, a number to treat 10, and a diverse event of an absolute risk increase of 10, but also a longer stay on the mechanical ventilator and a longer ICU stay. In addition, there is uncertainty about mortality and other outcomes. So things to consider. Well, we talked about the prognostic imbalances. That's a possibility given the differences in severity of illness in the table. Could this have contributed to patients receiving more sedation, or is it an effect of baclofen? And could that have contributed to longer stay in the ICU and longer duration mechanical ventilation? Is very hard to say. Another question to ask ourselves is, which outcomes matter to patients? Personally, I would favor, being extubated sooner and being discharged from the ICU sooner, over being deeply sedated and not extubating myself, for instance. Again, different patients may have different preferences, and also given the uncertainty about some of the important outcomes, I don't think we have, from my personal perspective, much to support the routine use of this intervention. So in summary, I think there are several strengths of this trial. The idea is novel, which is great. It addresses clearly an understudied problem. The trial is a randomized design, the analysis, which I haven't touched on. I think the authors did a great job with the analysis. In terms of summary, some concerns about, as I mentioned before, just having a pilot phase to help designing the studies. The significant imprecision that we have seen limit the interpretation of the results. So we talked quite a bit about the possible prognostic imbalance. What some people may think it's trivial, but it's hard to say. Also, the safety issues that we have seen still require probably more studies before this intervention can be used. I would also say that the effect, if you believe it, I think you would agree that the magnitude of effect is still of uncertain benefit or uncertain magnitude. I think we all agree that safety of high dose probably needs further studies. Maybe perhaps future studies should use smaller dosing or maybe tailored to effect. Who knows? Thank you for the opportunity to share my thoughts. And again, I would like to congratulate the authors for their fantastic work addressing this understudied topic. If you have any questions, and I apologize, I'm not there today personally. It's going to be 5 a.m. in the morning in Hamilton. If there are any questions, I'm happy to answer them on Twitter or by email. Thank you.
Okay, thank you very much, Waleed, for a fascinating editorial. Hopefully Kareem and Michael will have had a chance to listen to that, and they might have a moment now to respond to some of the points that Waleed has made. Kareem and Michael, were you able to hear that okay?
Yes, we just finished to hear the video. Yeah.
Excellent.
And,
are there any initial comments you'd like to open with in response to Waleed's editorial?
Yeah, so first of all, thank you, Waleed, for this editorial. I think you point a very important aspect of this study. So maybe we can take a point-by-point response to these questions and remarks. So first of all, yes, we acknowledge that there was no specific pilot study in terms of application, but the pharmacological study we built before starting this trial was kind of pilot study, but yeah, the number of patients was quite weak, so 20 patients. You also noticed that patients in the Baclofen group were more severe with SAPS-2 score much higher. So, and when you look at the prediction of this score, mortality was predicted about 30% in the placebo group and 40% in the Baclofen group. So, as you noticed, it can explain why there was little difference regarding mortality, and also may explain why patients were more deeply sedated. So regarding the number of inclusion center, yes, you noticed that there was a lot of center including, and some centers had a very weak number of inclusion, and indeed at one point of the study, inclusion were quite hard, and that's why we extended the number of centers. The data analysis was blinded to the randomization group at the beginning when she discovered the data. So yes, but there was no adjudication for the primary outcome. So one point that is quite important is You mentioned the average RAS score and the average recurrent sedation agitation scale. So to be honest, there was no difference in the mean SAS score between groups, but it appeared that expressing SAS score in groups, so 1, 2, 3, or more than 4, was more intuitive for the reader to understand that yes, patients in the Baclofen group had deeper sedation. You also mentioned that one negative point was that there was no difference for agitation-related events at day 28. That's right, but our primary criteria was a binary criteria. So if you present at least one, you will be in the group of yes, you have an agitation-related event. So the longer you wait, the higher the chance to belong to the group with agitation is high. To our mind, one important point is that the number of total events over the treatment period or at day 28 increases with time, and the gap also increases with the time. So,
yes, I would like to express some comments. First of all, I would like to thank Walid for this terrific editorial, highlighting the strengths and the limitations of our study. The main issue here, I think, and I fully agree with Walid, is to define if Baclofen is beneficial without any safety issue. I think this is the main point, and from the results of our study, it's quite difficult to answer in a straight way, because our study was powered for the primary outcome, agitation, and a posteriori we could figure out that the level of the rate, of the primary outcome was lower than expected. So maybe we're a little underpowered, but the study is positive for the primary outcome. If we are looking at the secondary outcomes, like time on ventilator, I feel like this is not really, this cannot be considered as side effect, but probably better than it could be considered as exploratory outcomes. So if I globalize the message, I think that yes, the study is positive for sure regarding agitation. Second, it was probably a posteriori underpowered, but the main issue again is to know if this is beneficial, and we cannot answer to this question. I think that to answer to this question, we have to monitor patient-centered outcome like PTSD at 6 months or 1 year to know exactly if the administration of Baclofen, whether the dose is high or low. I hope that we have clearly demonstrated that with the pharmacokinetic study, even at higher dose than the dose promoted by some agency, we can monitor safely Baclofen in the plasma and adapt it to maintain a good safety profile. I think that the step forward will be to, and we will do this with our results, to perform the sub-study to know exactly if at 6 months or 1 year or 2 years after the ICU stay, there is a beneficial effect of the drug.
Fantastic. Michael and Kareem, thanks for taking the time to respond to Walid's comments and his editorial. We have time now for some questions from our chat function on the live stream and also from Twitter, and my colleague Katrina Kelly will join us in the meeting for this.
Kareem and Michael, thank you, and Waleed, thank you again for your editorial. Several questions coming through on our live feed. What other sedatives and analgesics were excluded? There's been some comment on what other clinicians use using chlordiazepoxide, clonidine, and dexmedetomidine. Do you have any comment on that?
Sorry, we couldn't hear you very clearly. I don't know if this is the mic. Could you ask again the question?
Some clinicians are wanting to know, were other sedatives and analgesics excluded from your study? And there's some comment made that they would be regularly using methods such as chlordiazepoxide, clonidine, or dexmedetomidine.
Okay, so I'm not quite sure I understand all the, but so patients with allergy to baclofen were excluded, and also patients with celiac disease were excluded because a kind of excipient was present in the drug. So regarding the co-sedative and co-analgesia, yes, patients with clonidine or dexmedetomidine were included and could be included. And you have this in the supplemental data of the article. But regarding the wide variety of sedative and analgesic, there was no difference regarding the use of this sedative in between groups.
I don't remember, Michael. Do you remember the percentage of patients with clonidine or dexmedetomidine at the inclusion? Around?
Yes, it was less than 10%.
Okay, in each group.
Yes.
You made some comment that some patients had their baclofen temporarily discontinued. Was that a common event? And what were your parameters for recommencing the baclofen therapy in that patient group?
Okay, so your question was about discontinuation of the therapy? Yeah, so in fact, in our pilot study, so a kind of pilot study, but in this study, which was closely monitored, there was no kind of withdrawal syndrome of baclofen. And you will see also in the supplemental that the withdrawal score to assess alcohol withdrawal, but can do a parallel with the baclofen. Patients were calm, and very few patients present withdrawal syndrome. So, and we have some patients in our center that stop baclofen on the day of their discharge, and on the following days in the medical corridor. So, well, there was no issue.
Thank you. Been some comment about, as you alluded to, the baclofen group appeared drowsier and had a longer time to be liberated from mechanical ventilation. Do you feel this is because the group were over sedated, and was this maybe a failure of protocol of other adjuncts that were used to sedate the patient during their stay?
Yeah, so you are talking about the length of mechanical ventilation. That's it. Yeah. So yes, indeed, patients with deeper sedation may have longer length of ventilation, but as pointed by Waleed, so we can't conclude at anything because it was an exploratory secondary endpoint. That's the first point. And the second point is that I don't know if I prefer being ventilated one more day and wake up without agitation, without auto-extubation, without ablation of drains, or being ventilated one day less and present agitation. So I have no response.
I think that for a more accurate use, providing that we have the data from Baclo trial, for a more accurate use of Baclofen, probably that we should, of course, continue to monitor the dosage of Baclofen first to avoid side effects, and in the same time to monitor with the SAS scale the level of sedation, because as you said, probably that some patients were over sedated, but as mentioned before, we don't have any recommendation for this kind of patients, which render the situation complex, and probably this is because we didn't have any evidence providing good level of evidence from RCT trials before this trial. So I think that if we want to use Baclofen in this kind of patients, we should first, of course, use dosage to be sure that this is close to the level of the renal function, and in the same time, we should closely monitor the level of sedation, whatever the sedative drug we use with the SAS scale, probably.
Okay, thank you. And I suppose one final comment is, we mentioned that the average alcohol intake was 5 units per day. Do you think that would have a dose effect? Or, you know, we certainly see patients in our units would have a much higher alcohol consumption than that. Would you have any comment on that?
So some reviewer asked us a subgroup analysis, but when we try to find if there was an interaction between the level of alcohol intake, so from just unhealthy alcohol use to heavy drinker, there was no effect of the amount of the daily or weekly alcohol intake on the primary outcome. So we did not present subgroup analysis.
Okay, merci beaucoup. I'll hand you back to Rob. Thanks.
Thank you very much. Merci.
Super. Thank you very much, Katrina. We'll move into the panel discussion now, and we will be joined by Marion Campbell, Kathy Rowan, Morton Highlander-Moller, and Chris Nixon, who I've introduced earlier. We'll maybe start with a clinician in just a moment. One thing that I did see on Twitter, very interesting comment from Jay Nesbitt, who is a frequent attender at the meeting, I'm delighted to say. He's tweeted, "Baccalaureate trial take home. If struggling to achieve adequate sedation in a mechanically ventilated alcoholic patient with alcohol misuse disorder, Baclofen is safe, but may result in prolonged ventilation and ICU stay, and caution with dosing in renal impairment." Karim and Michael, is that a fair summary?
Yes, absolutely, Rob. I think it's a fair summary. We don't have answers to all of this, but yes, this is a fair summary.
Okay, great, thank you. We'll move into the panel discussion, and I'll start with a clinician. Morton, what are your first thoughts on the Baccalaureate trial results?
Well, first of all, congratulations for the completion of a nice trial and also a nice presentation and your soon-to-be publication in JAMA. So what I'm wondering about is the clinical implications. So both as a researcher, but also as a everyday clinical specialist, what do I do in daily clinical practice? Should I start using Baclofen?
Yes, Morton, very good question. Of course, thank you for the comment. From that point, I don't think that we can, apart from expert teams, I feel like we are now expert team because we are working on that for many times, and we monitored very tightly our patients. We performed the samples to look at the dosage of Baclofen. Apart from this, no, clearly I don't think now with this dosage of 150 milligrams daily. I don't think that from our results we can recommend a daily use of baclofen even in our population, heavy drinker or whatever it is, because we don't have enough data to sustain this kind of statement for sure. Yes. Again, the very important point will be if we can demonstrate, not in this study, of course, maybe in our sub-study, if we can demonstrate a difference between baclofen group and placebo group, let's say 2 years after the ICU discharge in terms of, I think, PTSD. But this is an expectation.
Yeah. So is it fair to say that you are somewhat worried about the undesirable effects of baclofen?
No, not really the worried, but we are not afraid about the side effect of baclofen because the safety monitoring was give a very positive results. But we should warn a clinician that using baclofen, which is probably an quite a strong sedative, implies that you have to monitor closely sedation and to adapt other sedative and analgesic in order not to have delayed awakening and prolonged mechanical ventilation or lack of say. So that's our response.
Yes, I fully agree with Michael. Of course, you will say that we're below the threshold of toxicity for sure, and for a large term. But the issue, of course, is that we delay from our results, even if it's exploratory. We delay probably the winning from ventilation. The patients are deeper sedated, so it's a fact, I think.
And at the opposite, I rather disagree with the fact that you say yes, the primary outcome is positive because the patients were more deeply sedative, but I don't think that's the reason, because in fact when you stop sedation and when you want to win mechanical ventilation, so whatever the sedative are used, you may have agitation-related events. So I don't think there is a direct link between the sedation and the positivity for the primary outcome.
Okay, we'll move on now. We'll stay with the clinicians just for a moment, and then I'll move on to Marion and Kathy in a second. A question for Chris Nixon. It would appear that we get less agitation, but more sedation. And Michael has just touched on this. Would a similar result be seen with just using more sedation? Have we replaced one sedative with another? Have we just bought more time for the effects of potential alcohol withdrawal syndrome to wear off? Perhaps you could comment on that, and then I'll bring Kareem and Michael in on that afterwards.
Yeah, so I think that's a really good point, Rob. And I guess that's something that I was thinking too, and can't say I know the answer to that particular question, because I kind of wonder that is a possibility. I guess, you know, what is baclofen? It's a GABA B antagonist. So what we're kind of expecting there is, agonist. So there is this possibility, certainly in overdose, one of the theories is that it just binds all GABA receptors and contributes to more sedation. And in overdose, you know, that's the main side effect that we see, over sedation. And that's kind of what we're seeing in this study too. I wouldn't call this an overdose. It's more like 200 milligrams in one pop is when I would usually be concerned about significant side effects. But there are So baclofen's also used in maintaining abstinence. So apart from withdrawal, but maintaining abstinence. So there's a thought that there's GABA B receptors that interact with the mesolimbic system and the reward system in the brain and actually suppresses the urge for alcohol. So there's really two possibilities, that baclofen is a substitute or an additive sedative, or that it's doing something else to do with alcohol withdrawal or cravings for ethanol. And I'm not 100% sure which it is based on the study, because I guess the way it looks on paper, it's possible that if we just turned up our other sedation, maybe we could achieve the same effect. And I guess I think of some of the trauma patients that we have where, you know, you try and desedate them and they wake up scrambled and you're like, well, let's give them another day, turn up the sedation again, turn it down the next day and they wake up okay. And it is an interesting outcome. I think it's really fascinating that the authors of this study have really put alcohol and even psychosocial disorders in ICU on the map, I think, a little bit with this study, because it's so neglected. And all of the treatments that we're doing in ICU, you know, we don't really know what any of them do or what the side effects are. So baclofen, it's an off-patent drug. It's probably the reason why we don't have a lot of data on it is that there's not a lot of dollars in it. So I commend the authors for looking at it, but I think it is just the beginning of a journey to figuring out exactly what the role of it is.
Thanks, Chris. So Kareem and Michael, I think this would be a really key message to come out of this trial and for people to understand this trial correctly. Can you comment again just on the increase in sedation and maybe buying time with baclofen versus just turning the usual IV sedative up?
Okay, yes. Okay, thank you for this comment, because there is two types of response for regarding sedation. So let's imagine you give very high dose of midazolam to your patient compared with placebo. I'm not quite sure that this patient, when you will stop midazolam because of delayed awakening, I'm not quite sure this patient will not present agitation because in fact he will wake up when he will have clear this midazolam. So this is the second response. So maybe there is a specific effect of baclofen on agitation, and as you mentioned, that's one of the possibility that the author studying abstinence exposed as an hypothesis. So there may be a specific effect of baclofen, but because patients were under sedation, so with quite deep sedation and also additive sedative like midazolam and analgesics, the abstinence side of this drug was hidden by the sedation, so we can't conclude on this point. And that's why we try as a secondary outcome to monitor the withdrawal scale of the patient in the 7 days following extubation. But because we have not only patients with alcohol dependence, but also alcohol abuse without dependence, or just unhealthy without dependence. So this case was probably not perfectly did not perfectly fit our population to show if there was a difference.
Great, thank you. We'll move to the statisticians and methodologists, Marion Campbell and Kathy Rowan. Marion is, amongst her many duties, a statistician in Aberdeen. She's also a methodologist and a trialist. Kathy Rowan leads ICNARC and the ICNARC Clinical Trials Unit and has vast experience in running trials. So, Marion, I'll turn to you first. You've read the protocol, you've seen the stats plan for this. Just in a very quick run through, how did it all look to you as it was presented?
Thanks very much. And first of all, really to thank the investigators, as it's been said, really putting this clinical indication on the map. There really isn't much evidence before this trial around this area. So first of all, real congratulations for doing that. But I guess there were a couple of things that spoke to me as I read the protocol and I heard the results of the trial. And one was really what the authors alluded to, which was actually that, first of all, the absolute risk reduction was much lower than they had expected. So it was 10% as compared to 15%. But on top of that, the baseline rate in placebo was much lower than they had planned for. So it's almost a dual difference. So I guess my question would be, first of all, is this still the same patient population you expected? Because the baseline rate you originally expected for agitation was up at 42%, but actually what you saw in the trial was down at 29%. So that exaggerates the possible differences from the protocol with what you saw in the trial, and added to the fact that then the difference in the absolute risk reduction just makes me question a little bit the underlying assumptions and whether you really feel that the trial as run was the trial you thought you would run, and is it some differential in the patients that has led to this? So that's the first thing. And then the second thing I would like a little bit of comment on is obviously the confidence interval for the effect size is really wide. So it runs, I think I took a note of it, it runs from 0.34 right up to really a tiny difference potentially of 0.98. And so again, on top of the fact that things changed from the protocol, how confident are you as investigators that this is a true effect and not potentially just a chance effect? Because actually it was really near the null effect. And given the concerns about mortality, I guess one would want to really explore that viewpoint. So it's just a couple of comments which I'd like the investigators to comment on.
Thank you very much, Marianne. This is two major points from a statistical perspective and from the design of every clinical trial. So Michael, maybe you can start with the answers to these questions.
Yes. So yeah, you're right. The population of the kind of pilot study. So population of the pilot pharmacological study is exactly the same that in this trial, but the population in which we found 42% agitation-related events included also patients without mechanical ventilation in the raw data. So that and the explanation of the Rennes University Hospital Arnaud Gacoin also include patients without ventilation. So that's why maybe can explain why the incidence of agitation was not quite the same between these two studies. So for the second question, so yes, indeed there is a wide confidence interval for the primary outcome, but we feel quite confident regarding the clinical applicability of these results because of the secondary outcome, which were the number of agitation-related events per group. Because yes, confidence interval, but this is a binary outcome. So it did not reflect the total number of events. And when you look at the total number of events in the placebo group at day 28, so it's quite huge. So more than 110 events for 150 patients. So yes, for this point, we feel like the confidence interval is wide, but
Yes, I would like to complement because that I think this is a key issue, the problem of the wide confidence interval. First answer, I'm reasonably confident, not enthusiastic about our results, but as Michael said, reasonably confident because the secondary outcome, even if it's descriptive, kind of confirm the primary to me. Come back to the percent of primary outcome that was lower than expected. This is something that we observed in other study we performed, for example, in a study on corticosteroid published in JAMA in 2011, the Hippolyte study, we had exactly the same issue. I think that there is probably a secular trend because when we designed the study, and we had some percentage of the primary outcome in a group of patients quite similar to the population in the Baclofen trial. And when we performed the study, of course, I think we improved the care of patients, even if it's only 2 years after. So maybe there is a kind of secular trend explaining that. I don't know if you agree with that, but it's a hypothesis.
Here we are. It had to happen. I'd speak with the mute function on. So, Kathy, Waleed mentioned a point about baseline imbalance. Can you comment how important that might be in this trial? Of course, there's the counter argument as well that there are other covariates that aren't measured and which may balance these out. Could you just make a quick comment on that, please?
Sure. Thanks, Rob. What a wonderful thing to be having a discussion like this. Isn't this wonderful? What's about critical care reviews, that ability to present your trial and we all get a good discussion. And congratulations, guys. I think it's a great trial and I really like to see a subject that we probably haven't looked at enough being brought to the fore. So yeah, I've got a couple of things that actually link into that imbalance, Rob. One would be, I noticed that 2,146 people met your inclusion criteria and 314 ended up in your trial. That's about 14%. Kind of, you told us about the 1,832 that didn't get in. It'd be really interesting to understand the exclusion criteria. Marion's talked about your population you get into your trial, your event rates. And sometimes it can be related to those people who get excluded and the exclusion criteria that they meet. The other thing that I'm really intrigued by this trial is this kind of sort of significance in that primary outcome that's lost in the secondary outcome. And forgive me, I'm not clinical, so here we go. You had a small imbalance in the table. So our Baclofen group were more alcoholics, or forgive me, they seemed to have more alcoholic problems, as I understood it. They then go into the trial and we hear that sort of they go on to receive greater doses of sedation. Now, as I understand it, you can't have an agitation-related event if you're heavily sedated, if that makes sense. It's at the period you're coming out of sedation that you get agitated and you may then be able to have an agitation-related event. And so I suppose there's this problem that I'm just wondering whether, as you go out to 28 days, there's a question around what's your primary outcome and your secondary outcome to 28 days in ICU. If I pulled my devices off on the ward after ICU, were you measuring that? And then this longer stay of the Baclofen group in ICU, if it is measured in ICU, might mean that you just shifted the window for measuring agitation-related events in the Baclofen group because they were more sedated for longer, if that made sense. So I'm just wondering whether the transition of seeing a difference and then not seeing a difference is actually a shift in one group for the period when they were sort of off sedation and able to be agitated and have an agitated-related event. So that's sort of my main sort of feeling about this. Generalizability, who are those 1,800? Because I want to know whether the alcoholics in the United Kingdom, you know, it's generalizable to them, you know, us being a very nation of not drinkers. And then obviously this notion of whether actually all you saw was a later kind of opportunity to capture the agitation-related events in the Baclofen group because of the greater sedation, but the longer stay and longer mechanical ventilation. But congratulations nonetheless.
Thank you very much.
So the second question is a bit more difficult, so I will start with the first one. So you're right, there is quite a lot of exclusion criteria. So sometimes it can be seen as a negative side of a study, but in fact, the drug agency, the French drug agency, which is very hard for our clinical trial, asked us to exclude a high number of patients with many medical problems in their medical story, such as schizophrenia or such as patients with Parkinson's disease, because we wanted to use a very high dose of Baclofen, so they were worried about the interaction between their personal treatment and Baclofen. So that's one reason why
we didn't want to exclude all these patients, but we had no choice.
Yeah, for the second point, yes, your hypothesis is that maybe agitation at day 28 is not different between groups because, in fact, the treatment is stopped. So the effect become more or less important. So that's a possibility. And the other one is that at day 28 in the ICU, there was less patients because the mean duration of stay in our ICU and in the participating center is about 7 to 10 days, in fact. So at day 28, there was less patients. So, and because this outcome, as mentioned in the supplemental data, was only monitored in the ICU, so we have a less number of patients.
Were there more Baclofen patients in the ICU at 28 days than not?
The mean length of stay was, as mentioned in the table 2, a bit longer, but at day 28, I don't remember exactly the data, but I can't respond.
Okay, great. We're coming to the end of the session. It's been absolutely fantastic talking about the baccalaureate trial results. I'll finish with one quick question for each of our 4 clinicians. So Kareem, Mick, Morton, and Chris. We've heard the results. Should we now start using Baclofen? So France first, over to Nantes.
Yes, okay. Yes. The question, as you mentioned, is obvious for the audience. As I mentioned before, from the result of this trial, even if it's the first randomized multi-center trial on that topic, and even if I feel like we had good evidence regarding pharmacokinetics, regarding safety of the drug, as I mentioned before, the statistical analysis show that the study is positive. But as it was mentioned before, with some pitfalls, of course, regarding the power of the study, regarding the wide confidence interval, of course, and regarding the secondary outcome, we don't know exactly why. Is it specific or not the fact that the patients in the Baclofen group are longer ventilated, are deeper sedated? They are a little bit more severe from the table 1, but we cannot be sure of that. They are a little bit more alcoholic. We cannot be sure of that. There are some issues about the exact level of sedation. So my feeling is that no, we cannot today say to the audience, please use the Baclofen to your alcoholic patients in ICU. Regarding our ICU, because as in England we have some patients with alcoholic issue, we use Baclofen because we work on that topic for many years. But no, of course, our data are not enough to provide this kind of recommendation.
Okay, and Michael, I presume you would agree with that then?
Yeah, sure.
Excellent. Okay, so Chris Nixon down to Melbourne.
Yeah, hard to add anything different to what I think the authors of the study have said, which I think is a very circumspect and considered answer, which this is hopefully the beginning of finding out new stuff about how to manage alcohol withdrawal in ICU, and that there may be a role for Baclofen. But I think there's at least another study there before we should be changing practice.
Yes, fully agree with that. Thank you, Chris.
Excellent. And we will finish in Copenhagen with Morten, where we started our panel discussion. Morten, I presume you won't be using this given the 3 answers we've had before.
No, I fully agree with the comment. So I think we need more firm data confirming this finding. We also need to interpret the findings in light of the existing evidence base and maybe update the existing evidence. And then finally, I think it's important, as alluded to by Walid, that we ask patients, what do they prefer? Increased sedation or other things? So we need to ask them, I think. So more research needed also here.
Excellent. And I'm sure Kathy and Marion would agree with the more research needed on that front. Okay, I'll need to draw the session to a close. We have just gone over time a little bit. Would particularly like to thank Karim and Michael for a beautiful presentation of the baccalaureate trial results and a very, very considered explanation and description of the interpretation of that trial. Chris, Morten, Kathy, Marion, thank you all very much for joining us in the panel discussion, and Walid in Hamilton, Canada, thank you so much for taking the time to put the editorial together. Yes. I'll finish with just one last thing. Karim, you mentioned the publication. Can you just let our audience know where that's coming and when that's coming?
Yes, we are already, the paper was just accepted in JAMA yesterday. So of course, I don't know the date of publication. It's under embargo, but it is accepted in the JAMA since yesterday.
Fantastic. Something to look forward to. So in the next few weeks, keep an eye on JAMA. Thank you very much, everyone.
Thank you. Thank you very much, Rob. Thank you, all of you. Thank you for the great discussion. Bye-bye.
Cheers. Bye-bye.